So when I was in medical school, we were first taught that your adipose tissue, your fat cells, is just this benign tissue that just insulates your body and helps you store calories for when you need energy. Not true. It ends up being your largest endocrine gland. So your fat cells were found like in the early 2000s to make estrogen. That's where like the original, man boobs kind of thing came in.
Hello, I'm Virgil and welcome to another show of Second Opinion with Dr. Jesse Haggard. I'm Virgil again.
I'm Dr. Haggard, and today we're going to talk about ancillary medications using testosterone therapy.
Wait, you said testosterone.
Right, well, we already did an episode with testosterone. We talked about testosterone, PSA test, all the problems everybody thinks that testosterone has with prostate cancer, heart disease, and those are the main ones. But there's a lot of other things that can go on.
Time out. We're going to just clear a rumor right now. I have a question.
All right.
Does testosterone shrink the old huevos, honey?
That is our first topic.
Oh, so there you go. We got the subject. True.
Yes, so we've talked about testosterone, some of the big things like, again, prostate cancer and heart disease, but testosterone therapy does have other potential side effects that are much more minor, most people would agree.
Okay.
And so the first one is when you take testosterone exogenously, meaning from another source, your body has a thermostat in your brain that says there's plenty of testosterone around, so we don't need to make any, right? So your body stops production or slows it down. So that can be a problem because if you're taking testosterone, obviously you have low testosterone usually in the first place, and then as you take testosterone, if you produce less over time, then you become more reliant.
Dependent on it, yeah.
Yeah, more dependent on the testosterone.
So is testosterone good or bad? Because like if someone wants to get off of it, then they're going to be miserable and probably a hardcore.
Well, if you take testosterone because of some of the symptoms we talked about, remember the Adam questionnaire, those 10 symptoms, if you have those symptoms, then testosterone is usually a good thing if it fixes it. Now, there's also somewhere in between. The medications that we're going to talk about can be used in conjunction with testosterone to offset the adverse effects of having your testicles shrink or produce less testosterone, which usually goes hand in hand. Or if you're not sure if you want to try testosterone or maybe something in between, because many people can actually take these category medications we're going to talk about to build their own testosterone production up, to actually encourage their body to make more testosterone.
So I have a question. I've always wondered this, and this is just me asking a personal question. So with testosterone, does it help your sperm count to get a girl a lot more pregnant, like quicker? I want to know if that's true or false.
Yes and no. If you have super low levels of testosterone, taking testosterone will usually improve your sperm count.
Really? Okay.
However, if you have normal to higher levels of testosterone, taking exogenous testosterone will usually over time reduce your sperm count.
Okay. So if you want to have a baby, do it while you're on testosterone.
Well, depends.
Allegedly.
The first category of medications to answer that question has to do with your testicles, which why I have the Spaceballs cup over here for today's episode.
I love it.
So we have HCG, is human chorionic gonadotropin, is an injection also known as Pregnil or Novarel. And we have clomiphene citrate, the name brand is Clomid. And these medications stimulate your own production of testosterone.
Interesting. So, when you said all of those, to me, that just sounded like some sort of STD. That's all I know, because gross.
Well, that's why we say HCG instead of chorionic gonadotropin.
HCG, STD, honey. I don't know.
So HCG is interesting. So it's an injection that usually would do anywhere from 1 to 3 times a week. And it's a subcutaneous injection, like we talked about other subcutaneous injections. And it stimulates your production of testosterone directly to the testicles. And that's interesting because then the clomiphene citrate is a capsule or a tablet, and you can take that anywhere from 1 to 1 every other day, 1 a day. That's usually the most common way I see it dosed. And that stimulates your production through your pituitary gland to then tell your testicles to produce testosterone. So depending on why the person has the issue, one route might be better than the other. But most commonly, it's the HPA axis, which we talked about before, hypothalamic pituitary gonadal axis. So that's why we say HPG axis. So that's where most people that are taking testosterone will benefit, is by taking clomiphene citrate is the generic, again, Clomid is the name brand, but taking that in conjunction with their testosterone. Now, one of the things that I go through in my book about taking these ancillary medications is most commonly, especially when you have, I think, people that learn about taking testosterone from other people, especially in a gym setting or whatnot, right? The bro science, you always hear it called, is they will do everything in cycles. And so my book offers a different idea, and that is looking at physiology of men when they're young. When we're young, we don't have really high testosterone for 3 months, and then low testosterone for a month or two, and then back and forth. Our bodies don't cycle. So my argument in the book, especially with all the science that I did and other research, you can absolutely stay on testosterone indefinitely without
for the rest
cycling.
of your life?
Without cycling, I should say.
So, okay, we'll just get a little personal right now. I take testosterone, okay? After the cycle is done, then you've got to get on that, to make sure you don't get the titties. You know what I mean? And then you could go back on it. And now you're saying it could be indefinite?
Yes. So if you take a smaller dose, rather than, my analogy on this is you take a really big dose of testosterone for 3 months, and then you take a really big dose of a bunch of rescue medications. And so you're going back and forth, back and forth.
That's what I do.
But I have a lot of evidence and experience working with thousands of people over the years where you can take testosterone, whether it's an injection, a cream, whatever, and then you take a small dose of something that's going to mimic your body's production of testosterone, which is typically FSH and LH, so follicle stimulating hormone and luteinizing hormone. So you stimulate both of those, and as you're taking testosterone, then you don't have the side effects of having your testicles shrink, having your sperm count go down.
Being emotional.
Clomiphene citrate also has some estrogen agonist effects as well. So it increases your testosterone by blocking estrogen.
Okay.
And anastrozole or Arimidex, we'll talk about in a little bit more later, but that has a similar effect. It's just not nearly as strong to mimic LH and FSH. But both work. I've used both for years. They're super safe. Wildly enough, though, HCG over the last year got super expensive and difficult to come by. But clomiphene citrate, you can get made from a compounding pharmacy, and you can usually get them made in 25 milligram capsules is the most common dose I see.
Okay.
And then you take like one a day or one every other day, depending on how much of the effect you need.
This is also in his book. If you all want to know more, get way more into debt with it, you can read the book and it'll let you know a lot more than what we're just talking about right now.
Yeah, and it has all the references in there so you can look them up directly yourself. Now, our next thing is what can also happen with testosterone when you take it is it can convert to estrogen, like you said.
Yeah.
Right? You get like gynecomastias. So there are lots of estrogen blockers. The most common are tamoxifen or anastrozole. Anastrozole is the most common one. It's also the strongest one. And it has a super long half-life. And you can take it twice a week, once a week. It just depends on how high your estrogen levels are. And honestly, rather than trying to guess, those are really helpful to measure. Having too much estrogen can be a problem with or without testosterone therapy. So when I was in medical school, we were first taught that your adipose tissue, your fat cells, is just this benign tissue that just insulates your body and helps you store calories for when you need energy. Not true. It ends up being your largest endocrine gland. So your fat cells were found like in the early 2000s to make estrogen. That's where like the original, man boobs kind of thing came in. When overweight guys started developing like breast tissue, it's because their fat cells were making so much estrogen that they actually were developing breast tissue. So that's interesting because that's one of the things also that I noticed when I was in practice is when you have a lot of overweight men, and I told you I used to work with a lot of type 2 diabetic patients, but that's why testosterone I think was so beneficial for them, because you get a lot of overweight men and then now they have a relative testosterone deficiency because they make so much estrogen because they're so overweight. So many times without testosterone, I would stick these overweight men on estrogen blockers and they would have effects like they were taking testosterone. Because now you're knocking down the estrogen levels. So besides estrogen conversion from testosterone, the other thing that testosterone can be converted to is DHT, or dihydrotestosterone, and that is typically what causes the male pattern baldness, extra body hair growth, and also can be one of the culprits of makes prostates enlarge that can mess with urinary flow. So when you have elevated DHT, those are your main 3 side effects you're looking for. Now, even though I said before, I feel like estrogen is a really good thing to check on a laboratory analysis, DHT, not so much. Like if you've already experiencing these effects, or if you've never started it, then that might be something to look at. But otherwise, elevated DHT is not always a problem. And that's another thing that I give the science and show my experience with in the book. The 2 medications that you can take in order to reduce DHT are finasteride or dutasteride. Now, both of them they work the same way. They're both 5-alpha reductase inhibitors. However, the finasteride, even though it's FDA approved for hair loss and Avodart is not, I got away from prescribing finasteride a long time ago because I saw it firsthand clinically. I don't recommend it, even though you can use it. It is also, again, the one that's FDA approved for hair loss. But Avodart, if you look up the head-to-head trials with finasteride and Avodart wins every time. And it's been around for 20 plus years, super safe. And also, it's going to reduce any sort of prostate-related urinary flow problems that can also develop while you're taking testosterone, again, if you're converting to DHT and so forth. And when you take Avodart, it's pretty fast. Like, if you have a urinary issue, you'll see results usually within 2 to 4 weeks. Now, the hair loss, regrowing, that takes time, right? Because you got to grow new hair.
Yeah.
So most of the time, you're not going to see a significant amount of results, actual hair changes for 2-3 months, unless you are having active hair loss in the shower and whatnot. You'll notice that usually within the first month.
Yeah.
You are taking one of these, correct?
Yes, I am. Let me tell you something. Okay, so I wish I had a before and after picture, and I'm like asking my husband because I swear he'll find one to hold against me, and he's looking for it. But I swear I had straight up that Jewish cap on my head, like bald, like it looked like that Jewish cap, like it looked like that. And then I had like little hairs here, but like look, what? Hold on, let's see a close up of this. Look at this, Jewish hat is almost gone. Yes, and I love it. And you know what? I don't feel moody or anything either off of it.
Yeah. Hey, did you notice any side effects?
No.
So one of the listed side effects is about 20% of men will notice a little difficulty with erectile function. But I didn't see that side effect when I prescribed Avodart because the majority of the time I prescribed it with testosterone. So my experience is if you are taking testosterone and the dutasteride or Avodart, you're most likely not going to have that worry. So I just wanted to let our audience know, like, yeah, there is documented a significant portion of the people that take it did have documented problems with erectile dysfunction, but I just clinically didn't see it, again, because I was combining it with testosterone. So I can't really find good research taking both of those together versus taking just Avodart or dutasteride by itself. That would be a good clinical trial, but I have not seen anything like that. If somebody has seen it, by all means, post it in the comments. So have you noticed any problems while taking this?
No, I haven't. No, I've no problems at all, actually. Not even mood swings.
So this is my whole point when we were talking about cycling things before, is if you discontinue this medication or possibly discontinue the testosterone, it might imbalance your hormones from what they are right now that's working well for you. So once you get the results you're looking for, I found that most people can go down and have like a maintenance dose. And again, this has a super long half-life as well. It's about 5 weeks for one pill. So that's how long it stays in your system. So most people can take like one a week for maintenance, which isn't bad.
Well, like I'm taking one every day, right? You're supposed to take one every day. That's what I've been doing.
That's to achieve the regrowth of the hair. That's that kind of dose usually. And also, when you look at the studies, it doesn't change the hairline in the front nearly as much as it affects the back of the hair specifically for 5-alpha reductase inhibitor medications.
Okay.
But again, back to this idea about cycling. If you find a nice dose of both testosterone and the DHT blocker, or again, also if you take one of the other medications that stimulate your own production of testosterone, then you have this nice balance of all three things possibly that you would just maintain, and that way you're not doing this roller coaster, yo-yo, up-down hormones, rescue mission to try to save your testicular atrophy. That also, equates to ejaculate volume, because sometimes that is affected when you take large amounts of testosterone or take testosterone for a long time and you don't do any of these other medications to stimulate your own production of testosterone. So that's where I really believe that trying to work with your practitioner to make sure you can find a nice balance of all of these categories of medications that are required, and everybody's metabolically different. And again, if you convert a lot of testosterone or of the other metabolites to estrogen, and that could be as simple as having more weight loss. I mean, having less body fat might be a strategy, but in the meantime, maybe you do take an estrogen blocker.
So that's our episode for today. If you are interested in his book, you can get it on Amazon or you can just get it through our website.
Super.
Okay, so we'll see y'all on the next episode.
Follow my podcast on drjessehaggard.com.